we're so glad to have you visit us today. Thank you.
Well, I really do appreciate the opportunity to come talk. I'll try to stay put. I tend to pace, but I'll stay here for a few minutes. Yes, I'd like to talk to you about the surgical options for ulcerative colitis, and I added familial polyposis coli, which we see a fair amount of at CHOP. I'm going to start with saying that I have no disclosures, even though throughout my talk, because I'm a surgeon who loves gadgets and technology and how they can improve the way we take care of our patients. So even though it'll sound like a 30-minute long Ethicon infomercial, I don't have any financial interest in any of these companies. But I just love the fact that we are changing the way we do things for hopefully for the better for most of our patients. But I do have some confessions. One is, and Aaron will probably tell you that almost every time I do one of these operations, or these multiple operations at one time, how much I'll often say things like, I hate this operation. So that's my first confession. The truth is I respect this operation, but I think we have a long way to go. And that's the second part, the second confession, and that is that it's a pretty good operation, but I'm hesitant to tell anyone that it's a great operation. In fact, I use the same corny joke every time that it's the worst operation for ulcerative colitis, except for all the others. But again, I hope to show you that I feel like as a surgeon I've evolved in terms of how I've approached this operation, and I think that the science has evolved as well. And finally, I'm hoping, and I was glad to see that, not glad to see that there was a complication of a patient who had a J pouch, but that's a topic of discussion here, because when I come to give lectures, I actually would love to leave having learned something, even though I'm here to hopefully tell you some great things about what we do at CHOP. So feel free to give me a hard time, to correct me, to try to teach me something. Aaron will tell you I'm always open to suggestions and trying to learn and get better as I go along. All right, so sorry about all that. So we're going to talk a little bit about the indications, about some of the surgical techniques that we used. We're spoiled in children. We don't usually have patients with BMIs over 30. These are usually otherwise generally very healthy kids. Some of the kids with UC, of course, can be quite sick. And then we'll talk a little bit about some of the benefits of the operation, and I'll talk about our outcomes. We're in the process of reviewing our experience with J pouch, and again, sorry about the shorthand. J pouch, of course, refers to the colectomy, the proctectomy, the J pouch pull through, and with or without an ileostomy, which I'll talk about our approach. But we're proud of our results. In general, especially because we're a pediatric hospital, the numbers are relatively small. But I think something that we're proud of anyway. So we'll talk about a series of 91 patients in the last 12 years or so that we're in the process of reviewing now. So ulcerative colitis, I don't want to go into a lot of detail. You all know all about ulcerative colitis. The nice thing, the reason why J pouch is the J pouch operation is the ulcerative colitis patients are amenable to it, of course, is that it affects essentially only the colon and the rectum and only the mucosa, and that's important for the part of the operation that is sort of a pediatric flavor, and that is the endorectal dissection that I'll get into. And technically it's cured, if you will, by removing the colon and the rectum. And I always tell my patients, look, it's sorry that we have to remove your colon. Luckily it's not a vital organ, but it sure is a convenient organ to have, and I'm sorry that we have to remove it, but we'll get you back to a normal lifestyle. Hopefully that's obviously the goal. So what are the indications? They're sort of obvious, I think, at this point. The patients who are medically refractory. I was really hoping, and I'm still hopeful that the GI folks will come up with a cure, and I'll find something else to do with my time. I don't really mind not having to operate on patients with Crohn's and colitis anymore. Obviously, for their sake, I'm happy to help them when I can. But even in the biological era, we've probably saved some people from the operating room, but disappointingly few. Luckily, we don't have that many who have fulminant colitis. That seemed to be more common in the old days. We recently had our first case of toxic megacolon that we've seen at CHOP probably in 15 years. But luckily, that's few and far between. There's somewhat sort of semi-elective operations for the most part. Some patients are doing okay, but they can't seem to get off of their steroids. They're weaning the prednisone, and every time they get below a certain daily dose, they tend to have a flare-up, and so some of those patients are coming to us asking for colectomy. And of course, some of them have complications, but we don't see those very often anymore either, the stovepipe colons and the perforations and things like that, and the toxic megacolon. And familial polyposis coli, we're seeing more and more. And I think it's because our GI folks have a center, and so they see a lot of patients. And they'll send us a patient with who have too many. They're happy to surveil these patients, but once they get beyond a certain number, and every GI doctor has a certain number, but when they're carpeted like this, they generally send the patients to us. And even though these are mostly teenagers, early teenagers, in general between 10 and 15 years of age, and of course they want them to try to keep their colon for as long as possible, but it's not always possible. And of course the indications are dysplasia, too numerous to count polyps, or if in the rare patients who have symptoms, protein losing enteropathy, for example, or bleeding, but also very rare. All right, so we'll jump into surgical options, and I always have to mention colectomy, proctectomy, and ileostomy, and permanent ileostomy, which of course for years and years before the ileo-anal pull-through operation became fashionable and safe, was the standard. In fact, up until recently, most articles would say this is the standard for ulcerative colitis, and all subsequent operations need to be compared to this, because the truth is it's a very good operation. The patients are healthy and they do well. They're usually off medications, and of course the problem is the ileostomy. We're lucky in that our kids are very resilient. They don't let an ileostomy stop them. They do all kinds of amazing things, but for a lot of patients, as we can understand, really hate their ileostomy, and they don't like the lifestyle, especially when they're young adults, and for a lot of reasons they don't like it. So that's why the other operations, the J-pouch operation developed, and I'll go into the history of it a little bit in a minute. So then we still have requests sometimes for patients who read so much about the J-pouch online that they're afraid of it, and ask us to just do their colectomy and an ileostomy, and then when they feel better, they want us to just keep their native rectum, and they'll take medication. They feel your proctitis is better than ulcerative colitis. We don't usually do that. We've had some requests. I'd be interested to hear if this is still an option that is offered to adults with ulcerative colitis. But we don't do that just because the proctitis can actually be, once you get to the point where you need a colectomy, the proctitis can be quite difficult to manage. More and more in some of the young patients, we have a lot of patients, or more and more patients now, who we're calling very early onset IBD. And these are patients who sometimes have a phenotype that looks for all the world like ulcerative colitis, but we're finding out that many of them actually have a form of Crohn's disease, or there's some indeterminate colitis that maybe is a third diagnosis. And some of those patients do really well with just ileostomy diversion. It's a temporary measure. It does leave us a little bit in limbo. When do you close the ileostomy? What's going to happen when we do that? But for some of our younger patients, ileostomy diversion alone is an option. Although most of the teenagers, when we've tried that, their colitis just rages on, and we end up doing a colectomy a few weeks later. But certainly something to consider. And then, of course, there's the J-pouch, where we do a colectomy and ileostomy and move on to proctectomy and the pouch. This was the original article. I've always been interested in the history of these surgical techniques, and it's always fun to look back. I mean, 1978 doesn't seem that long ago, at least to somebody like me, even though it's before many of you in the audience were born. And apparently, Sir Alan Parkes was a famous colorectal surgeon in London, and he published a series. And it's amazing what they could get away with publishing back then, because there were only a handful of patients. There were 8 patients, and 3 of them weren't available for follow-up. And so, and the results, they were okay for the time, but we would probably look back. But actually, there are some interesting lessons to learn here. What's interesting is that he created an S-pouch. The J-pouch has become sort of standard. And some of the younger folks may not know that there's the J-pouch, and obviously it's called that because of the shape of the letter J that we create. But then you can fold it 3 times and create an S-pouch, and others have even described a W-pouch, I guess, where you put many folds. And those are great. They're great reservoirs, but the problem is I believe that the larger the pouch, the more stasis, the more pouchitis you have. In fact, there's the group in Michigan who I'll discuss later. I don't know if they still do it this way, but they, for years, would only do a straight ileal anastomosis. They didn't do any pouch at all. And they had very good results from the standpoint of pouchitis, but their frequency of stooling was quite high, even though they claimed that it was close to that of a J pouch after a few years. I'm not sure we believe that. But it's interesting that they described a J pouch or an S pouch in this operation, but actually what he described was a Koch pouch, which we don't have a lot of experience with in kids. But the Koch pouch had been around since 1969, and Dr. Koch apparently had some great results, or pretty good results, that haven't been able to be reproduced by many others. But what Dr. Parks did was create a Koch pouch, but he put it in where the rectum used to be. And interestingly, he did an endorectal dissection, just like we do in pediatrics for the most part, which I understand is pretty rare still in adults. Of course, he did a hand-sewn anastomosis, and he described very specifically going all the way down to the dentate line. And I'll have some pictures about that because I'm still confused about the anal anatomy, as I'm sure most of you are. And this is an illustration from his actual article where you can see they sutured it in quite low. And interesting, he did it in 2 stages. Dr. Halabi, I think, mentioned the traditional 2-stage approach, which was to do the colectomy, the proctectomy, and the J pouch, but then protect the anastomosis with an ileostomy. And then the second phase would be to take down the ileostomy later. You'll see, I'll talk about it. The contemporary, what I call a contemporary 2-stage operation, is a little bit different. But interestingly, this operation that they did back then, they left 3 drains, one in the abdomen, one in the perirectal space, and one tube in the actual catheter in the pouch itself. And of the 5 patients, they had a fair number of complications. And I'm not being critical because you'll see my results are pretty close to this, I think. But he had 2 abscesses, presumably small leaks. He had 1 small bowel obstruction, very common problem in these patients. I'm not sure why. It's been shown that small bowel obstruction, adhesive small bowel obstruction, is much more common in patients who've had a colectomy, no matter what operation they ultimately get. I'm not 100% sure why that is. He describes that 2 of the 5 were incontinent. I think our results are much better nowadays, and I think it may have to do with the whole dentate line business. And he had 1 patient who didn't like to catheterize himself, he claims in the article, and insisted that the pouch be removed 6 months later. So luckily that doesn't happen very often. But the way he devised the pouch, these patients weren't designed to have continence. It was basically, again, a Koch pouch that was hidden. It wasn't on the abdomen. They used to catheterize themselves 3 or 4 times a day or more. And so I could see where it was maybe more cosmetically appealing, but certainly not more technically appealing for those patients. So again, this is how I split it up in my mind, the traditional 2-stage approach and the contemporary 2-stage approach. Almost all of our patients in we've really moved towards the ulcerative colitis patients being done in 2 stages, and I'll go through the reasons why in a minute. But the contemporary approach is to do the colectomy. I messed that up. It's the colectomy without the proctectomy. It's colectomy with, I should say, ileostomy, and then we do the J pouch IPA at the time of the proctectomy at the 2nd stage, and then we generally don't do a 3rd stage where we give the patient an ileostomy. And so just because we have to exaggerate the improvements in terms of the minimally invasive approaches that we use. This is in the old days, and even back when I was a resident, a lot of these patients ended up, because when you do a colectomy, you have to get to all corners of the abdomen. There will be a long stem to stern midline incision. But nowadays we do it laparoscopically. You'll notice I still do a fan and steel incision. I've dabbled in robotics, if you will, and we do a lot of course, minimally invasive surgery. But I've not really felt that we're quite ready to do an endorectal dissection laparoscopically yet. I still feel like I'm learning how to do it open. Believe it or not, after all these years, it's technically somewhat challenging, and the bleeding can become an issue. So I still do it with a fan and steel, what I euphemistically call the original minimally invasive incision. So for our colectomies, when I first started doing these, and most of the patients would end up with a fan and steel, I would do a hand-assisted approach because I found it a very challenging operation, but we don't do that anymore. So we start with 3 5mm ports. We of course mobilize the colon. Here's my first plug. The 5mm ligature has really been a really nice technique to mobilize the colon and safely take the mesentery. Now again, this may be something that we use in pediatrics and we get away with it, but that may be difficult in adult patients who have much more mesenteric fat and much larger vessels. And of course, The nice thing also about this operation is that we very rarely have to deal with patients who have carcinoma, so we don't have to take the entire mesentery. We can just take it where it's convenient and safe. We had one patient with FAP years ago who had an occult carcinoma in the rectum. We recognized that something wasn't quite right during the operation, and so we sort of did a more formal operation as though he might have rectal cancer, and lo and behold, he did end up having that, but he's done well. He was 24 at the time, and is probably 34 now. So then, of course, we use the endostapler to divide the colon. We usually leave about a 10 or 15 centimeter segment just in case they turn out to have Crohn's. When they look at the pathology, we have something to deal with, to be able to sew to later. And it also has not posed an issue in terms of proctitis or the residual colitis, since the patient will be diverted. And then through the ileostomy incision, we can usually remove the entire colon. It's sometimes boggy, but it's not like a typical Crohn's colon, for example. They can usually be removed pretty easily. And then we do a standard Brook ileostomy. And that's our colectomy. And we've gotten it down to about 2 hours or so. Again, we're lucky. The kids are usually thin, but these kids are usually pretty sick. And the reason why I don't think, and I think a lot of people don't like the idea of doing a proctectomy and a J-pouch at that point is, number one, it's really not necessary. They're really sick. What they need is to have 90% of their colon removed. And what happens is these patients really do amazingly well. They typically still stay about a week in the hospital, not really so much for medical surgical healing, but mostly to learn about their ostomy, to get used to it, and we give them the time to be ready to go out there in the world with their ostomy. But I'm still impressed. Some of these patients are quite ill. They're malnourished. They're cushingoid. They are anemic. They feel terrible, but the operation for some of these patients is really miraculous. We see them back in a month or two. Well, we see them back in a month, and then we see them back again in 2 or 3 months to assess whether they're ready for a J-pouch and review their pathology, etc. But they come off all of their medications. They wean off their steroids. They gain weight. They feel better. And I think that's one of the reasons why they probably come to not like their ileostomy but tolerate it, is because they associate it with feeling better. Some of these kids are quite miserable. And that's why I just don't think, I don't know, maybe I'm chicken, maybe in this day and age we can probably get away with a one-stage operation, or just to be more aggressive and do everything all up front. But again, these patients are so sick, it just feels like a more cautious approach is reasonable, and it's only 2 or 3 months in most cases before we can offer them the J-pouch, the proctectomy and J-pouch. So now these patients come back, they're usually grateful. Hopefully their pathology confirmed that it's ulcerative colitis, and we'll get into the whole, how often these turn into Crohn's disease. I think that the old paradigm of it being a dichotomy, very, very strict, you either have ulcerative colitis or Crohn's, is probably not accurate. I think we're going to find that a lot of these patients with indeterminate colitis either have a third diagnosis, but I think it's more of a spectrum is my guess. At least that's what it feels like right now. So we're still trying to figure this out. A lot of these very early onset IBD patients actually have an autoimmune disorder that can be identified by a genetic or by mutation, and some of them have gone on to getting bone marrow transplants and are cured of their IBD. So it makes you wonder if that could be a potential option for patients with Crohn's disease. But I don't want to get into Crohn's disease, a diagnosis I hate even more than ulcerative colitis. So, so when we bring them back, these patients are now healthy. So at this point, we plan to take down their ileostomy for good. So we take down the ileostomy, and then again, I start off with a fan and steel. You all were using wound protectors before I even knew they existed, but I can't live without them now. And I think it really helps, not only just in terms of exposure and keeping things clean, but just for making it a technically much easier operation. And then we mobilize a small bowel mesentery. And when I up until about 6 or 7 years ago, when I started doing them using the EEA stapler, and we'll go into some of that technical detail in a minute, and I used to do them all by hand, which is the way I was taught and the way a lot of people maybe still do it out there in pediatrics. You'd have to get so much length on that small bowel mesentery, and it was a huge source of anxiety for me and for most surgeons probably, because by the time you mobilize the small bowel mesentery and you go all the way up to the duodenum and you cut across sometimes to beneath the pancreas, and you're mobilizing it as much as you can, and you do that thing, I didn't realize you call it pie crusting, but it's a great analogy, where you do all these steps to try to get length, because you had to do it by hand. You had to pull it out through the anus and do it by hand. it was extremely challenging. So the EEA stapler has really revolutionized it for me. You really don't have to get as much length and put the J pouch at risk, because back in the day we used to see J pouches turn ischemic before our eyes, or at least get congested, and you'd worry about the blood flow. That has not been an issue ever since. And then we mobilized the rectum. Again, one of my least favorite parts of the operation. I remember the days when we'd have long right angles and try to get those pedicles, and no matter how hard we tried, one would get away from us, and there'd be lots of bleeding. But the impact ligature has really, again, I feel like a motivational speaker here. It's changed my life, and it'll change your life too. But again, even though they're very expensive, I think it's well worth it in terms of the time and the mostly the confidence that you've gotten those blood vessels under control. Now, this is where we differ probably from where the adult colorectal surgeons do, because I understand, I believe, and I don't want to speak for you, but my understanding is that you don't generally do an endorectal dissection. In other words, we feel we can strip the mucosa and save the muscle cuff of the rectum, of the lower rectum, and that's how Dr. Parks described it. That's how we do it in Hirschsprung's disease. So you would wonder, though, why do we do it? All the studies suggest that there's no difference in terms of functional results. And I think partly, maybe it's just an homage to our history. We kind of can't accept that. We also claim that we can get a little lower, so we have a very low incidence of cuffitis. We don't usually have to leave a cuff, because we can get all the way down to the anal transition zone. And we also, I think we believe that we're doing an operation that may have to, we've created a pouch now that we are hoping is going to function for maybe 80, 90 years, whereas, if I were getting this operation, you wouldn't have to worry about it lasting that long. So, I don't know, we can argue about that. That'll be a nice topic for discussion someday, to talk about the pros and cons of doing it. It does make the operation a little longer and a little more difficult, but it certainly feels very gratifying to see that funnel of muscle and bring that J pouch through there, with the idea that maybe we've preserved some nerves or preserved some function for long term. I don't know. And for a long time, we never thought that we could do it with a stapled technique, the way you guys have taught us to do, until the folks in Michigan. I call it the Michigan technique. That's why it's in quotes. I don't know if that's what people call it, but I'm really indebted to these folks, many of whom I know and who are highly respected in pediatric surgery, Jim Geiger and Dr. Teitelbaum, Herschel, and Corin back in 2003. So what they proposed was doing the endorectal dissection the way we normally do it, all the way down to the top of the crypts, or somewhere in that anal transition zone. And again, you can tell me maybe where I should put this anastomosis. The dentate line is too low, the rectum proper is too high, but somewhere in there preserves continence and reduces the risk of pouchitis and stasis. So I think we're still learning about that. It's one of the things that I and probably most of us still struggle with. But then what they decided to do was they staple off the rectum, and then they evert it. So this is supposed to be an everted rectum. And the idea is that those are the tops of the crypts that you can see externally, and that's where they staple it. And so they leave a centimeter of rectum, because that's your EEA stapler is going to take that away, right, presumably. And then they use a TA stapler to staple across. Now, sometimes I'll do that externally, sometimes I do it internally. But Aaron will tell you I have to check a million times. Am I low enough? Am I low enough? There are no landmarks that I've learned internally to know how low you are. So you have to just keep checking through the anus and hope that you get it just right. And so I think we're getting there in terms of getting it right. And then, of course, it's important, again, to preserve the anal transition zone, whatever that is. And it's different in most patients, in all patients, I think. Some of them seem to be only 2 centimeters long. Some of them seem to be more like 5 centimeters long. So it's really tough. It helps when they have active proctitis, because then you can tell when the inflammation is reduced, and so we go a little bit lower. And I always thought, well, why not just go all the way down to the dentate line? But we've learned the hard way from the Hirschsprung's operation, where we preserve the anal transition zone in children, at least a centimeter is the standard, that continence can become an issue. So I think there's something about the sensory function of this of the rectum and anus that are important to preserve. And then, of course, in our kids, we use a 75 millimeter GIA stapler to create that J pouch. We find that that's a reasonable length. Sometimes in a larger patient, maybe, or an older patient, we might go a little bit longer, rarely more than 100 centimeters. I'd be interested to hear what your standard is in adults. My guess is it's closer to a 10 centimeter long pouch. But we find that the 8 centimeter pouch accommodates well and provides adequate reservoir function for these patients. And then again, we do and this is something that I've really only just learned probably about 8 years ago or so, and of course mine look just like this every time, but they it's really come a long way. The hand-sewn anastomosis, when my fellow and I would be down in the below the patient who's in the lithotomy position, struggling for room and trying to get just the right bite. This has changed my life, and I think it's really helped my patients a lot. And of course, we test it with air under saline, and we do all those things. We check the donuts, and we found some very good results. We've had fellows over the years who tell me that, oh no, they learned that you should always use the smallest stapler that you can get away with, and others who would say that you get the largest one, because that's how I learn about what they do in the adult world through our fellows who come from their general surgery residencies. But we try to just use the size stapler that fits appropriately without too much stretch or tearing and without being too small. I still don't like the 21 millimeter stapler, just seems too small. A lot of these patients would get strictures, but they usually respond to one anal dilation if they develop a stricture, and they do quite well. And again, this is the part where we have evolved, where we almost never feel the need to do an ileostomy at this stage. Again, these patients are healthy now that we've done the colectomy so many months before. They're not on steroids. They're well nourished. They're not usually morbidly obese. So we don't feel the need. And you can argue, well, maybe we just get away with it or whatever. But I think the studies will show when you review. Well, the studies, first of all, the older I get, the more I realize that every paper has an agenda. The authors are trying to sway you with a certain to their way of thinking. And there's also a lot of confirmation bias. I know when I read it, when I read an article that says that you don't need an ileostomy, I say, yeah, see there, I feel vindicated. But you could probably find just as many articles that say you should do it, or it's okay to do an ileostomy. But again, we haven't felt the need for it. I don't think the studies show that the leak rate is any lower. In fact, I'll show you our study. In our 91 patients, we had 4 leaks. 2 of them had an ileostomy when they had their leak. So for whatever that's worth, obviously it's not statistically valid, but I'm not sure that it really helps. You could argue that you might have more severe sepsis and have to undergo a second operation for an ileostomy if they have it without an ileostomy. But all right, now I'm sounding like I'm getting defensive, so I'll move on. But of course, this is what a nice J pouch looks like. We don't really do radiographic imaging anymore, but this is sort of from the history books. One of our patients who had a nice pouch, you can see the staple line of that delineates the J pouch. And this is back when we used to do ileostomies. So we used to do, occasionally we would do a third stage. And we would study the patient, of course, before, just to make sure that there was no leak and that there was a good function. So that's a pretty pouch, I think. I should also say that I never promise patients when they come to me that they're not going to wake up with an ileostomy. In other words, I tell them, and we haven't really seen this recently, but there may be technical reasons to do the right thing, to do the safe thing, of course. I mean, if tension is an issue, of course, I would do a J-pouch. If there's a leak that I don't feel confident in repairing, when I do the air test, of course, that patient probably should get an ileostomy. So there are technical reasons and safety reasons. I don't want to imply that I'm going to avoid that ileostomy just to show them, but you want to do the right thing for the patient, but we just don't feel that it's necessary in most of these patients. And I haven't really talked about FAP, but the FAP patients, again, these patients, and these are tougher, I think, to deal with, because we have to, for them, to have to deal with this operation, because they're going from feeling fine, feeling healthy. They just have these polyps that they hear about, maybe their uncle or their mom had, but now we're changing their lives. The patients with ulcerative colitis, they'll say, I'll take 5 bowel movements a day. I'm going 20 times a day now, so that's an improvement. But the patients with FAP, in a lot of ways, it's a lot sadder of a situation. But we have been routinely now for the last maybe, again, 8 or 10 years, doing them all in one stage. So we do the colectomy, we do the proctectomy, we do the J-pouch, and we've been able to avoid an ileostomy without regrets, so far in these patients, and they're quite grateful. So again, feel free to tell me that you think I'm doing something crazy and I'm going to regret it, and I'm happy to learn from that. But so far we've been really happy. And this is what I tell families about our results. We've gotten the operation down. These used to routinely take between 6 and 8 hours. We've gotten them down to now 3 or 4 hours, and I'll show you some data that confirm that. Our patients, though, still stay close to 6 or 7 days in the hospital, and this has something to do with the function of the small bowel afterwards that I can't figure out. I always blamed it on the length of the operation. It was an 8-hour operation. Of course, it's going to take a week to recover. But even now that the operation is quicker, less blood loss, fewer complications, immediate complications, they still take a while to come around. And it's something about the ileus in these patients that I haven't figured out yet. Of course, I tell them that Imodium is going to be their best friend. I think fiber is sort of falling by the wayside a little bit, but occasionally we'll try it in the patient who's still having a lot of bowel movements. It may help. And so most of our patients, and this is what we've been able to achieve, we've actually sent surveys out to all of our patients. I was hoping to have that data by now, but we've only gotten 17 replies, and my research coordinator won't let me see the results yet because we don't have enough. Because I'd like to know what their function really is, because these patients are sort of lost to our follow-up, and of course they're followed by GI, but most of them seem to be doing really well, and we tell them that the best you could probably achieve is 4 or 5 bowel movements a day. Some of them still have to get up in the middle of the night to go in the middle of the night. Most of them can still hold it for a little while, not like they used to in the old days when they had a functioning colon. And we've only had 2 patients who came to us with incontinence. They were both patients who had neurologic issues, and one was a patient with cognitive delay, and one with a neurologic problem. I think, if I recall, it was a spina bifida, who had incontinence coming into the operation, so they still were incontinent after. But none of the patients who had continence before are incontinent now. With one small caveat, we have a few patients, and no more than 5 that I know that I'm aware of, and I think only 3 who have sometimes soiled at night, and I blame that on that they're not awakened by the sensation that they need to have a bowel movement. So that we're still working on. But in general, their continence is quite good, certainly enough to play sports and live a normal life. And that's what our goal ultimately is, that these kids have a normal lifestyle, that they don't have the stigma of a chronic disease, and they can go to school and play sports and date and get married, everything that everyone else has. And this is my sort of bare bones enhanced recovery after surgery that doesn't apply to these patients. I don't know how to. So most of my colorectal patients, my bowel resections, Aaron will tell you, I'm very aggressive. No NG tube. I tell the families after their ileocecal resection for Crohn's disease that they'll be home within 2 or 3 days, and for the most part that's true. I let them drink right away. I don't do a lot of the things that you guys are all doing. We haven't learned how to use gabapentin and some of these. I don't even use it, so I don't know the name. I forgot the name of the drug that they use to help relieve your postoperative ileus. We love Toradol. We've gotten away with it for many years. I know there's some controversy about that. We, of course, in a patient with a J pouch, we wouldn't offer them a suppository. They generally don't need it, but we offer the patients a suppository when they've had other operations. But again, it just doesn't seem to apply to this operation. I feed them right away. They all look great. I call it the J pouch honeymoon, right? After they look great for 2 days, and the residents come in the morning like, you look great, you're going to go home soon. Next thing you know, they fall apart. They're bloated. I don't know if it's a partial bowel obstruction. I don't know if it's a profound ileus, but then they look terrible for 2 or 3 days, and then they recover. So again, maybe you can give me some insight. I haven't figured it out yet. I find it frustrating, but a little less frustrating now that I just know to expect it and not worry about it too much. And they generally do quite well. Usually they're not having 4 or 5 bowel movements by day 7 when they go home. They're usually having 10 to 15, but most of them have good continence and the confidence to go out there in the world and do their thing. Although not usually to go back to school for sometimes a semester. All right, so these are the data that I have, and it's interesting. In my quality work, I like to tell my colleagues, quality improvement's not something to be afraid of. It's basically just using data to give you feedback so that you can change your practice to improve your outcomes. And it's kind of a cycle, right? You create more data and you're trying to feedback. It sounds pretty benign, but mostly I've found that it's always a lesson in humility, because your results are never quite as good as you remembered them to be, or that you thought they were. But still, I think these are results to be proud of, mostly because, and you can call it a learning curve, it's an institutional learning curve, but this operation and our experience has evolved. When I think about it, I learned about this operation about 20 years after that initial report, and that was 20 years ago, so another 20 years have gone by. And it's not just the technology, I think it's the understanding of the physiology and the other things, the importance of nutrition and steroids and maybe the biologicals have played a role as well. So we had 91 patients since 2007 who have undergone this operation. Again, it's a pretty big experience in our pediatric surgery circles, so we're proud of that number, even though some adult centers that are quite busy probably see this many in 2 years. It's about 50-50 male-female. Most of our patients, of course, are ulcerative colitis. I threw in the 12 indeterminate there, and we can talk about whether we should be offering the operation to patients with indeterminate colitis. I think that some patients with indeterminate colitis clearly have a UC, I call it a UC phenotype. I think it's fair to offer it to them. I'm still not really bold enough to offer it to patients with Crohn's disease, even though some people claim, that maybe 40 or 50% of those patients will do okay. So maybe we should think about it now that the biologicals can maybe keep them out of trouble. But it seems like you're burning a bridge that if you fail and the pouch has to be removed, that's a long time for that patient to have to deal with a permanent ileostomy. But again, maybe you can teach me a little bit about that too. I'm not sure if we're ready to take that plunge. Those are the patients that we do an ileorectostomy to if they really want to have their ileostomy taken away. And you can see how we've broken up into stages. More and more, the patients, we're shifting away from the 3-stage operation, moving towards 1 stage for the patients with FAP and 2-stage for patients with ulcerative colitis. And all of my patients, when I first took the job at CHOP, and Dr. Adzik said, you might have to do the J-pouch operation. Are you comfortable with that? It looks like you've done some. And, you could be our guy, or our person to do these operations. And I didn't say it out loud, but I'm thinking, oh, my partners are going to be so jealous, because this operation is just, they are not jealous at all. They love, they can't wait to send these patients to me, and they're happy that I'm there, fighting the good fight. So again, as much as I hate this operation, I love learning more and more about it as we go along. But more and more we're doing them in 2 stages, very few in 3 stages anymore, unless we feel it's necessary, and then we'll do, like I said, the right thing. Oh, and so stapled now, almost all of mine are stapled now. Occasionally there'll be a patient who's just not amenable to a stapled technique. And in fact, it's interesting, the first one that I did stapled, I believe, was a patient who was morbidly obese. Except in our patients, when we ask them to lose weight before their operation, they usually gain weight. And so, it's a strange thing. But I didn't feel I could do an adequate hand-sewn anastomosis, so I thought, well, let's offer them this, and it worked out really well, and so that made me a believer. And then these are our complications, again, warts and all, in here. The known leak rate has only been really 4 patients, and interestingly, 3 of them were in the patients with FAP. One of them was mine, a patient, the operation went well, we did it hand-sewn back in the day. She should have done beautifully, and instead she had a leak. And I still can't figure out why. We gave her an ileostomy. She subsequently did well, and we offered the same operation to her sister, who also had FAP. Surprisingly, they had the confidence to come back to me for the second sibling, and they both did extremely well. And 2 of them were patients of my partners who had done an ileostomy. They did them they planned to do it in 2 stages, and they developed a leak before their ileostomy was even taken down, which is puzzling to me. But I guess why couldn't it happen? I suppose. Why not? You notice that, and we don't see very many abscesses nowadays, and I think that's mostly because our SSI work has really progressed, and our SSI rate in general is lower, and so our SSI rate for these patients is lower. We also don't use drains, which I think actually, again, it's hard to tell because it's historical fact now, but I think our use of drains in the past increased our rate of abscess. And some of these obviously could be occult leaks. I'll grant you that. Some of them could be small leaks that we didn't really pick up on, and we drained them and they did fine. We're seeing a lot more strictures now that we're doing the EEA stapled technique. But I warned the families about it. They usually are patients who are doing really well for about a month or so, and then all of a sudden they're having increased frequency and maybe some accidents. And I say, oh, that's a stricture. We get them to the OR. We dilate them once. 5 minutes later, and they seem to do well. Those leaks, those strictures rarely recur. We've had our share of small bowel obstructions. Again, the adhesive small bowel obstructions obviously can happen after any abdominal operation, but it seems particularly common in these patients. We just had a patient who went back home to Virginia 2 months after his operation, went to his local hospital, had a closed loop obstruction, and lost some bowel, but is doing well now. I can't understand it. We're not big fans of Ceprafilm. I don't know if there's something else that you guys use that you found helps, but I haven't found it. I think that the takeaway from all this, without going into all the detail, is that the complication rate is very high. It's still a very challenging operation with lots of complications. But in general, and maybe again, maybe it's because they're kids and they are like, abscess, schmabscess or whatever, and they just move on and they recover quite nicely. The functional results have been quite good regardless, and we've been very happy about that. Pouchitis, I feel like we're seeing less pouchitis, but our pouchitis, we don't do biopsies, we don't confirm it. Any patient who has increased frequency or tenesmus or blood or mucus, we say, oh, you must have pouchitis, take some Cipro and Flagyl, you'll be okay. And most of those don't have chronic pouchitis. When I look back, we actually have about 10%, so about 9 or 10 patients in this cohort who have what you could be called chronic pouchitis, and about half of those have had Crohn's disease. Now, that's the other interesting thing about this operation is about patients who develop Crohn's disease after the fact. And I just saw a recent article that said if you follow them long enough, 20 years or more, 25% will end up having Crohn's disease. That's very disheartening to me, I have to say, because if anything, these patients, when they're younger, are even harder to distinguish Crohn's versus ulcerative colitis. So it could be that our rate might be 30 or 40%. I hope not. I guess time will tell. Hopefully those patients are doing well. If they get detected early enough, they can start a biological and we can maybe save their pouch. I'm hoping that'll be the next study I see in the coming years. But the whole business of Crohn's disease is tough. We had a patient just recently who their colectomy specimen showed no signs of Crohn's, but their proctectomy specimen did. So now they're on Humira and doing well, but it's only been a few months. So you can see our duration of the operation has gone down. We had a good year in 2017, but I think that's because we had a really fantastic senior fellow who helped me with most of those cases. So that's the Erin Brown effect, just to embarrass her a little bit. But again, we've down to 3 or 4 hours. I haven't been bold enough to try doing two in one day yet. I don't know if I have the stamina for it. But this is our length of stay. You can see, except for one bad year in 2009, pretty much everybody's been between 6 and 8 days of recovery. And again, I've just learned to accept it. Maybe we can get them out sooner. But the whole what we used to call fast track, the whole enhanced recovery after surgery protocol doesn't seem to really work for these kids. Although maybe I should try one of those medicines that the companies argue are good for postoperative ileus. All right, so I'm almost finished here. These are the lessons learned, and the operation is still challenging. I don't want to say like is a strong word, but I'm hating it less as time goes on. The complications are still frequent. It's one of those things. It's like central lines. You place 10 central lines and they go so well, you start feeling like you get the hang of it, and then you get a complication like the one you described today or something else, and you realize that it's just things are hard, and this is one of those hard operations. Overall, we've been very proud of our functional results, although I'll let you know, I'll give you follow-up next year. Hopefully we'll get some more of those surveys back. And the outcomes overall have been encouraging. Like I said, I send this out as a not a challenge, but a word of encouragement for the younger surgeons here. I'm hoping that you look at these results and you say, my generation, just like most of the things in the world, I guess, my generation, we're going to do better. We're going to make this a better operation for these kids. And I'm really hoping that you do and come back and teach me a lesson someday about it. There's still lots of questions. I didn't have a chance to talk about fertility, which is a big concern, because we were always taught that half of the women who have this operation will go on to have difficulty conceiving or carrying an infant to term. Although there was a recent Cochrane database that said that, I don't know, the data are still, the jury's still out on that, but it probably does have some effect. In our kids, we don't have the luxury of saying, why don't you keep your ileostomy until after you've had all your kids and then come back and we'll do the J pouch. These are 13 and 14-year-old kids who aren't going to go for that. And that's all I have. Sorry, I did that East Coast talk real fast at the end to make things go faster.
No, that's great. I think we've got a few minutes for questions, so let's open it up. Dr. Pokenauer.
I'm interested in the use of non-steroidals.
Yeah.
How long are you using for it all? Because it is something that people are concerned about with anastomosis.
Yeah, so we don't use it for, even though there are more data now suggesting that maybe we were a little bit hard on toradol, maybe it wasn't causing leaks, but we've had some leaks with colocolonic anastomosis or colorectal anastomosis. But I don't know if, again, maybe we're getting away with it because it's in kids and our GI folks are like, yeah, it should be okay, go ahead and try it. But we've used it for years, and I know that's not a ringing endorsement from a statistical standpoint, but we feel very comfortable using it for our ileocolonic or ileorectal anastomoses. And when we do our ileocecal resections for Crohn's, again, it's been a lifesaver for these kids. We've managed to get away from, they hardly get any narcotics afterwards. But it's a good point. Oh, really until they're taking PO pain meds. And we don't usually, we don't know if we should be sending them home with Motrin. That's a whole different story. But we might send them home on a little bit of oxycodone, and these kids really recover quite quickly. So it's only really for about 48 hours, typically. And then we have to get special permission to use it for an extra day if we feel like they need it. But we're not beyond that.
Dr. Hallory.
Very nice presentation. Thank you. I'm curious, like when you see those patients, and I saw that you have a high percentage of two-stage operation, which unfortunately I don't get it, but I don't get time to help your patients. I usually see patients who have failed like 3 or 4 biologics. They're on 40 milligrams of prednisone. So how many biologics do you guys like go through before you get this referral for a pouch?
Yeah, I mean, there are more and more biologicals, it seems like, coming out all the time. And our biggest problem is getting insurance coverage for some of the newer ones. And RGI folks, I think, have a reasonable approach, but most of our patients have gone through at least 2, and many of them 3 before they come to us. So you're right. When they come to us for their colectomy, they're usually very sick. Some of them have been hospitalized for a month while they're on TPN. They're trying to get better, and so we get them when they're quite ill. And luckily, again, I don't know if it's just a miracle of youth or what, but they really tolerate a colectomy, an ileostomy, operate subtotal colectomy and ileostomy amazingly well. And when we see them back, even on their first follow-up visit, 3 or 4 weeks post-op, they are different patients. They're almost unrecognizable. The color looks good, or whatever that means, and they're gaining weight already, and they feel. You can just tell. You can see the optimism in their faces. So it's probably different for a lot of the adult patients, is my guess, and that's why we feel more confident, I think, doing the second stage and stopping there without an ileostomy. I don't know what lessons there are to learn in the adults. If I get mine someday, they'll probably do it in 3 stages. Is my guess. Is my BMI.
Dr. Hirose.
Great talk, Dr. Mattei. Thanks for validating the rest of us have the same emotional response to that operation during an operation. Makes me feel better about saying what I say.
Yeah, I left the expletives out.
Yeah,
so.
I was going to say Dr. Hirose.
My question is about sexual function, because I don't think that we do a really good job of talking about this with our patients. And the adult literature, sort of their spotty reports of impaired sexual function. I'm curious how you talk to them about it and how you follow them, because it gets sensitive, certainly with the kids around puberty as well.
Yeah. Well, I think the truth is we don't know, and that's one of the. I don't know. That's probably maybe the reason why they're not sending back their surveys, because there is some aspect of the sexual function on that survey, and so maybe they're not comfortable talking about that, and maybe it kind of sours them on the whole thing. But yeah, it's a big question, and I do worry. I think we're going to probably find out that a fair number of patients are having retrograde ejaculation and a lot of the other complications that we know can happen. And then in women, of course, the whole fertility issue is still a big issue. So I have to say we probably don't do enough to talk about it, because I think if we do talk about it, we don't know. We're doing the best we can, and we're hoping that that was one of the arguments that even in Dr. Parks's paper, or Mr. Parks's paper from back in the day, that doing an endorectal dissection should preserve the nerves and preserve sexual function, but I don't know if we have the data to support that.
That was certainly the argument for in kids using the endorectal dissection versus the way you do it in adults. Dr. Hallory, how do you talk to your patients about these issues?
So when I see like a young female patient, it's not so much the sexual function, because if you operate on them and they usually don't have like an active colitis, it's easy to identify the nerves. I do most of my operations with a robot, so I get like a very good view of the nerves, and I stay on top of those. But for young female patients, I usually tell them that getting pregnant and having a pouch, if you think that 5 or 10 bowel movements are bad, try 20, because you have now a gram of uterus present on your pouch. So that's going to be an patients, I usually do them in 3 stages, and I tell them, I'll do a total colectomy, we'll have an ileostomy, it's easier to get pregnant with an ileostomy, and that you don't have to deal with pouch and pregnancy. But for young male patients, I usually quote like numbers like about 10% will have some sexual dysfunction. And usually they have really active colitis, they're on high dose steroids, because the planes are really not well defined in the pelvis. But I do tell them this.
Great question.
All right, Dr. Goodnight, we'll let you close the day.
Dr. Mattei, it's an extraordinary body of work. My question stems from operating on these early adolescents with cancer, which is devastating impact on their lives and that. I felt like I had an inordinate number of serious behavioral problems playing all throughout adolescence, being severe delinquency and so on. So do you see that you've got your kids are more prone to delinquency or other major behavioral problems?
No, I don't think so. No more than I think the average. I think I haven't really picked
The
up on
average
that.
adolescent.
Yeah, exactly.
There are a few of those parents in this room.
But yeah, that's an interesting question, but I haven't noticed that.
Well, thank you again. Really
Thank you.
appreciate it.
No, I appreciate it. Thank you. Really appreciate it.